Hi there, welcome back. This is part two of antibacterial agents. All right, so our next drug class are the macrolides. The prototype macrolide is erythromycin, but there are several other drugs in this class you may have heard of. Some of you may have heard of azithromycin. The brand name is Zithromax. That's a pretty commonly prescribed medication, commonly used for the treatment of community-acquired pneumonia. But we're going to focus on erythromycin as that's the prototype that's used for your boards, and it's also the prototype in your textbook. So these drugs work by inhibiting protein synthesis. They are considered broad spectrum. They work particularly well for chlamydial infections and pneumonia caused by M. pneumoniae, and that's why they're part of the treatment for community-acquired pneumonia. Adverse effects, some of the typical things you see with antibiotics, such as nausea, diarrhea, abdominal pain. But the one that really stands out, and I wish I had bolded this on your slide. So as you're listening, why don't you circle this, put a star next to it, and that is QT prolongation, specifically when this drug is combined with potent inhibitors of the P450 CYP3A4 enzyme. So this drug does cause QT prolongation. So for patients who have a congenital QT prolongation syndrome, this drug should not be used. So in terms of nursing implications, the drug can be taken with meals if the patient has GI upset. Now, the thing to know is that you have to double check prior to administering this with food whether or not the dosage form that you're giving is able to be given with food. Like I said, there are several different macrolides. Even erythromycin itself has several different forms. Some of them are okay with food and some are not. So keep that in mind. And then, like all of our antibiotics, instructing patients to complete the entire course of therapy is important. I would say an additional nursing implication is also warning the patient of the potential for drug-drug interactions because the 3A4 inhibitors the potent 3A4 inhibitors can create that increased risk for QT prolongation. Okay, so our next drug is clindamycin. The brand name is Cleocin. This drug is also a protein synthesis inhibitor. This drug is only used for anaerobic gram-negative infections and aerobic gram-positives. Frankly, its largest uses are the anaerobic gram-negative infections. Dosage forms, it comes in a variety of different forms. It comes as both an oral tablet and an oral liquid. It is available in a parenteral form that can be given intravenously or intramuscularly. The drug does have some adverse effects that you need to know for sure. It can cause GI upset. Again, almost all of our antibiotics fall into that group. However, this drug is associated with C. difficile-associated diarrhea, or CDAD. You absolutely have to know that. Of all of the antibiotics, this is the drug that's the most likely to cause C. difficile-associated diarrhea. And so you guys all know, I know you've heard of this before, or if you haven't, that's okay. But if you have, then you may have some background information or background knowledge about CDAD. But basically, it's a superinfection of the bowel caused by C. difficile. The patient will experience profuse watery diarrhea. They will have, possibly 10 to 20 watery diarrhea stools per day. They'll have pretty intense abdominal pain, fever, leukocytosis. Their stool can even have blood and mucus in it. It can occur within the first week of treatment, but it can also occur, cases have been reported as far out as 4 to 6 weeks after the drug has been discontinued. The thing about CDAD is that it requires treatment. If this condition is not treated, it will be fatal. So this is a very, very important thing to warn patients about, to make sure that they're educated, if they do complete a course of clindamycin, that they're educated that they should be watching out for the signs and symptoms of diarrhea, and if they occur, they need to contact their provider as soon as possible. This drug can also cause increases in hepatic enzymes, specifically AST and ALT. So that's another thing to keep in mind. Nursing implications, like a lot of the other antibiotics we talked about, giving this with a full glass of water can be helpful to minimize some of the GI problems. And then, of course, education. The most important piece of education for this drug is making sure patients understand the risk of diarrhea and what they need to do if they experience diarrhea. So the generally accepted advice is if they see that they're having more than 5 watery stools per day, they should call their provider immediately. And then, of course, educate, like we do for all antibiotics, educate patients on completing the entire course of therapy. Our next drug class are the aminoglycosides. The prototype that we will review is gentamicin. There are other aminoglycosides that I'm positive you guys will see when you begin your clinical practice. And in your clinicals currently, I'm sure you're already seeing some of these. Some of the names that you may recognize: tolbramycin, amikacin. These are other aminoglycosides that are commonly used. Aminoglycosides inhibit protein synthesis, and their use is for serious gram-negative infections. They can be used in conjunction with other antibiotics for treatment of gram-positive infections, but this is really just for the synergistic effects. These drugs have activity primarily against gram-negative infections, and we do reserve these drugs for serious infections. So drug-drug interactions, these drugs are ototoxic. They are also nephrotoxic, and they also can interact with other drugs that cause skeletal muscle relaxation. So I'll talk more exactly, when I talk about the adverse effects, I'll talk about how they're ototoxic and nephrotoxic. But for our purposes, what I want you guys to know is if you're combining aminoglycoside with another drug that's nephrotoxic, for example, vancomycin, can cause nephrotoxicity, then that cumulative effect is increased. And so even more reason to monitor closely, monitor renal function closely, make sure that the drug doses are adjusted appropriately. And then if you're administering this medication with another medication that can cause ototoxicity, one that comes to mind for me is Bumex. Bumex is a loop diuretic. It's kind of like Lasix. So that drug is also ototoxic. And so when those drugs are used together, one, you want to avoid the combination. But two, if they are used together, then monitoring is very important. And then I'll talk more about the skeletal muscle relaxants as well, but those are generally avoided in patients on aminoglycosides. Individual variation, so I already mentioned renal dysfunction. So patients who have renal dysfunction need their dose reduced. So the aminoglycosides are a group of drugs that we empirically start a dose, and then that dose will be titrated based on levels. So once the patient reaches steady state, which for aminoglycosides usually takes several doses, then levels will be drawn, and the patient's dose will be adjusted based on those levels. And so even that initial dose may need to be adjusted for renal dysfunction, even though we're going to closely monitor the levels in this patient. If that initial dose is too high, it can take quite some time for those levels to come down. And in that interim, patients are at risk for ototoxicity, and they're at risk for increased renal toxicity. And then also drug interactions. So there are, again, giving this drug along with other nephrotoxic drugs or other drugs that can be ototoxic is a concern. So looking for patients that are on those other drugs when you're about to administer aminoglycosides is an important thing to do. All right, so the adverse effects. I've talked about all of these already, but let's go into a little more detail. Nephrotoxicity, yes, this drug causes nephrotoxicity. And so patients with pre-existing renal dysfunction, the dose needs to be reduced. And then ongoing, we need to monitor patients' therapy very closely by monitoring their serum creatinine, their BUN, their creatinine clearance, as well as monitoring their plasma levels of drug because higher levels are associated with a higher risk of nephrotoxicity. The other very big concern with aminoglycosides is ototoxicity. The part of the reason for the concern is that it's not irreversible in all patients. So once it occurs, it can be permanent. So basically what happens is that these drugs accumulate in the inner ear, and that causes cellular injury, and specifically damage to the sensory hairs of the cochlea. This is related to excessive trough levels. So remember when I talked about vancomycin, I talked about trough levels and peak levels. The trough level is the lowest level in the body before the drug is redosed. So a trough is generally drawn 5 to even 30 minutes prior to the next dose. Usually it's about 5 minutes prior to the next dose. And so that's the lowest level in the body before you redose. So ototoxicity is related to patients who have elevated trough levels. And for that reason, trough levels are what we're most concerned with for aminoglycosides. And so you can see the two different types of ototoxicity that can occur with this drug. Obviously, like I said, this ototoxicity in many patients is irreversible. And so at the first sign of damage to the inner ear, the drug needs to be discontinued. Aminoglycosides, as I mentioned, can also induce some degree of neuromuscular blockade, and so which can result in paralysis. Not necessarily to the same level as what you would see from the neuromuscular blockers, but when the drug is combined with those, it can result in excessive neuromuscular blockade, which can be a problem. So let's talk about the traditional versus extended interval dosing for aminoglycosides. So I've already mentioned that aminoglycosides are used for treating serious infections. These drugs have been around for a long time, and there is a traditional approach to therapy and a newer approach to therapy, which is called the extended interval dosing. So the traditional approach to therapy is giving the drug around the clock, so usually twice a day or 3 times a day. The extended interval dosing is giving one very large dose just one time per day. And so that is, like I said, that's the newer approach. And so it's thought that this newer approach decreases the risk of nephrotoxicity. And that's because your trough, you're getting this really high peak, but then for an extended period of time, you've got a pretty low trough, and that decreases your adverse effects. But it also, because of the way the antibiotics work, the therapeutic effectiveness is not impacted. So with the extended interval dosing, the risk of nephrotoxicity is decreased, and that's a good thing. The levels that are drawn for an extended interval dosing scheme, we only do a trough because the peak won't tell us anything. The peak is going to be super duper high, in fact, scary high. But it's not the peak we worry about. In extended interval dosing, we just look at the troughs. And our goal is typically for the level to be less than 1 milligram per deciliter. Now, I already told you troughs will be drawn just before the next dose, usually about 5 minutes before the next dose. If you have a patient on traditional aminoglycoside dosing, you'll be obtaining both peaks and troughs, and the peak would be drawn 30 minutes after a 30-minute infusion. So basically an hour after the infusion is started is when the peak is drawn. Nursing implications. Like any drug that is monitored with plasma levels, it is extremely important to note the exact time of drug administration and as well as the exact time when the levels were obtained, because that information is very critical in interpreting the levels that are reported. Additionally, monitoring for ototoxicity and nephrotoxicity is very important. Okay, so our next drug class is the sulfonamides. There are quite a few sulfonamides, but the prototype that we'll talk about and the one that I expect you'll actually see in practice is sulfamethoxazole trimethoprim. The brand name is Bactrim. This is, while this drug has a relatively narrow spectrum of use, it is drug of choice for a couple conditions. So I expect you guys will see this in the inpatient setting as well as in the community setting, depending on where you work. The drug is typically abbreviated. The drug name is typically abbreviated because it's such a long name. So you might see the abbreviation SMZTMP, and that just stands for sulfamethoxazole trimethoprim. Hopefully with the newer electronic health records, you see less and less abbreviations. But for that one, that is a commonly used abbreviation. This drug interferes with bacterial folic acid synthesis, and that's how it exerts its therapeutic effect. Its uses, it is used for the treatment of and prophylaxis of UTIs, and it is also used for the treatment and prophylaxis of pneumocystis pneumonia. Pneumocystis is an opportunistic infection. It's not generally seen in patients with an intact immune system. Patients that you might see with pneumocystis pneumonia would be like HIV patients or oncology patients who are immunocompromised. We're going to talk quite a bit about opportunistic infections in the HIV lecture that's coming up. So we'll talk more about this organism at that time and this infection at that time. Individual variations, so sulfonamides are cleared through the kidneys. So in the setting of renal dysfunction, the dose needs to be adjusted. These drugs can also contribute to renal dysfunction, so monitoring for that's appropriate. And then another issue with the sulfonamides is allergy. So kind of like the penicillins and the cephalosporins where allergy was a major concern, sulfonamides, an allergy to a sulfonamide is a major concern. And so assessing for allergy prior to administration is very important. I have it bolded and italicized on your slide. This is one of the most important points that you should know about Bactrim, and that is that it interacts with warfarin. This drug inhibits the metabolism of warfarin. Bactrim is one of the strongest inhibitors of the metabolism of warfarin of all of the drugs that we have, and this results in an increased INR, which means the patient is at risk for bleeding. I can tell you when I worked in the inpatient setting, I ran an anticoagulation service in pediatrics for 2 years, and this interaction came up over and over again. I would come in on Monday morning, and over the weekend, Bactrim was started without it being detected as a problem by the prescriber or the pharmacy or the nurse that was administering the medication. And by Monday, even after just a couple doses, the patient's INR would skyrocket. So this is definitely one that you guys need to be familiar with. Adverse effects associated with sulfonamides. So I already mentioned the risk of an allergic response. And so typically the allergic response with this drug is a type of rash. But this drug can cause urticaria, pruritus. Photosensitivity is also a concern, and that is, in that case, patients need to be instructed to use sunblock if they're going to be in the sun, or really, frankly, just to avoid the sun altogether. This drug can cause hematologic effects. It can cause thrombocytopenia, could cause leukopenia, could even cause aplastic anemia. Luckily, that's pretty rare. And this drug can also cause hemolytic anemia. And I mentioned this early on. And this is patients who have a specific genetic issue called G6PD deficiency. Those patients are at risk for developing hemolytic anemia. This specific deficiency is more common among people of Mediterranean descent. It's also most common among African Americans. So something to consider when this drug is being prescribed. The drug can also lead to hyperkalemia, can also cause renal dysfunction, as I mentioned, which will manifest as elevated serum creatinine. And finally, you have to know this. So kernicterus, please circle this. I regret not bolding this. Additionally, hemolytic anemia or G6PD deficiency is also very important, so make sure you circle that, as is rash. I said allergy associated with sulfonamides is also very, very important. All of these adverse effects can occur, and I can tell you, I've seen patients that have had rash. I've seen patients on sulfonamides with photosensitivity. I've seen patients with a variety of different hematologic effects. I've certainly seen patients develop hyperkalemia and renal dysfunction on this drug. I personally have never encountered a patient that's developed kernicterus as a result of sulfonamide use. Thankfully, I can say thankfully I haven't encountered that personally. But I think that there's good education around this. I think that a lot of providers are well aware that this drug should not be used in pregnant or breastfeeding mothers, and it should also not be used in babies that are less than 2 months old. And the reason why is because the child can develop kernicterus. Kernicterus is a neurologic disorder that's caused by disposition of bilirubin in the brain. And that can be caused by sulfonamide antibiotics because sulfonamides displace bilirubin from their protein binding sites in the body, and that increased circulating bilirubin can cross the blood-brain barrier in the fetus or in the newborn baby, and it can deposit itself in the baby's brain. Now, that doesn't happen to us because our blood-brain barrier is intact, right? But a fetus, their blood-brain barrier is still developing, and even up to a couple months old, those babies they still do not have a completely intact blood-brain barrier. So definitely know about the risk of kernicterus, and that these drugs need to be avoided in pregnancy, breastfeeding, and children babies less than 2 months old. Nursing implications. So as I already mentioned, don't give to pregnant patients or patients who are nursing babies under 2 months old. Don't give to babies under 2 months old. Of course, like all of our antibiotics, instruct patients to take the entire course of therapy. Definitely advise patients to use sunblock if they plan to be in the sun. Make sure that they're advised to look out for the signs and symptoms of rash and other types of allergy. And then, of course, if you have a patient who is potentially on warfarin, then there needs to be a discussion around, we're going to have to decrease the dose until the patient is completed with their course of Bactrim, and then at that time, the warfarin dose will need to be increased again, and there'll be increased monitoring. So pretty specific scenario with warfarin, but for the rest of these things, these are more general instructions. Definitely be familiar with those. Okay, and our next drug class are the fluoroquinolones. This is a pretty commonly prescribed class of drugs. I do expect that you guys will see these drugs with regularity. The prototype fluoroquinolone is ciprofloxacin. The brand name is Cipro, but there are several fluoroquinolones on the market, so I imagine that you will come in contact with these drugs. They are protein synthesis inhibitors. They actually have a pretty broad spectrum of coverage. So they're used for a variety of types of infections. They can be used to treat lower respiratory tract infections, inner ear infections, soft tissue and bone infections. They're also used for UTIs. These are just some of the infections that these drugs are used for. They really do have a pretty broad spectrum of use. Now, with that said, these are broad spectrum, but they're not necessarily the drugs that we're going to use against highly resistant organisms, like our 5th generation cephalosporins or the carbapenems. So these have a broad spectrum, meaning that their coverage currently is pretty broad. And so because of the fact that they cover quite a few broad spectrum organisms, it is highly likely that these drugs will be controlled through the antibiotic stewardship program. If you work in a hospital or a health system, I would expect that these are drugs that require antibiotic approval. Individual variation, so renal impairment, so these drugs need to be dose adjusted in renal impairment, and then myasthenia gravis. Patients with myasthenia gravis should not receive these drugs because they can cause additive muscle weakness. And here's the thing about fluoroquinolones. They are involved in a lot of drug interactions. So I'm not going to ask you to memorize all of those, but what I want you to know is that this is a drug that's involved in lots of drug interactions. And so if we ask you a question on the exam related to drug interactions, your response should be, yes, this drug can be involved in lots of different drug interactions. In terms of adverse effects, tendinitis and tendon rupture is pretty rare, luckily. However, it can cause some serious morbidity. Patients usually start off by experiencing pain, swelling, and inflammation, and it's kind of like comes out of nowhere. So it's not like they're injured and then they start to experience this. It just kind of crops up. So patients need to be advised that if that does occur, they need to report it to their provider so they can be evaluated. Phototoxicity is also an issue with these drugs. So we've talked about several other classes where phototoxicity is of concern, like the sulfonamides and the tetracyclines. The fluoroquinolones also can cause pretty bad phototoxicity if the patient is in the sun and is not using sunblock. Other issues, dizziness, lightheadedness, they can also cause QT prolongation. In terms of nursing implications, these drugs are kind of like the tetracyclines in that they can bind up with um, certain substances like calcium or iron, and they form non-absorbable chelates, which means that they cannot be absorbed into systemic circulation and they can't exert their therapeutic effect. So the patient will experience therapeutic failure, and that's a problem, especially for some of the infections that these drugs are used to treat. It's a big issue if the patient's not actually getting their drug because they're taking it with a glass of milk or something along those lines. The recommendations for fluoroquinolones is that the fluoroquinolone be administered no sooner than 6 hours after the chelating agent, like milk or other dairy products or iron or antacids. So in terms of education points, educate patients on signs and symptoms of tendon damage. Make sure they understand they need to use sunscreen if they are in the sun. And then also definitely educate your patients about drug-drug interactions. I'm not saying you're going to tell them all of the different drug-drug interactions they might see, but you're going to say to them, look, this drug causes a lot of drug interactions. You're going to be on this drug for, 10 to 14 days. So if you are started on some other medication in the interim, you need to let them know that you're on fluoroquinolone and let that provider know so that they can assess whether or not there needs to be a change in therapy. Okay, and the last antibacterial agent that we're going to talk about is metronidazole. The brand name is Flagyl. This drug inhibits nucleic acid synthesis. This results in cell death. Its therapeutic use is pretty limited in that it is mostly for anaerobic bacteria. But it also is effective against some protozoans, such as Giardia or Trichomonas. One thing to know with certainty, you must know this, metronidazole is the drug of choice, the first line drug of choice for treatment of C. difficile. If your patient does not respond to metronidazole, then the second line agent is oral vancomycin. Oral vancomycin is 10 times more expensive than metronidazole. So for that reason, metronidazole is the first drug of choice for C. difficile. Individual variation, this drug should be adjusted for patients with severe hepatic impairment, so the dose may need to be adjusted. And just like when we talked about Bactrim, the other very important drug interaction with metronidazole is warfarin. So I told you about this interaction when we discussed warfarin, but I'm mentioning it again now as we talk about Flagyl. Again, kind of like Bactrim, Flagyl is used in the inpatient setting. It's used in the outpatient setting quite a bit too, but it's also used in the inpatient setting. And I can count numerous examples of patients who I saw personally who were either on warfarin and metronidazole was started, or vice versa, and ended up with issues with their INR. Adverse effects. So it causes nausea like a lot of the other antibacterial agents, but it can also cause a metallic taste, which you should let patients know about. It can also discolor the urine, make it a very dark color. One that I guess I should have bolded on this slide, disulfiram-like reactions with alcohol. So that very profound flushing, nausea, vomiting, very uncomfortable sensation for patients. Patients should not drink alcohol while they're taking metronidazole. It can also cause rare neurologic problems. These problems are associated with patients who need their dose adjusted because they've got hepatic impairment. So these are more likely if the dose is not adjusted appropriately. Nursing implications, patients must be educated about the alcohol and the reaction that could be seen, and they need to be educated not to drink alcohol while they are on this medication, and then of course completing the entire prescribed course of therapy, and that's education that we give for all of our antibacterial agents. Okay, and that's it. If you have questions about the antibacterial agents, please post them on the discussion board, and thank you for listening.